session on Phakic IOLS. So I request the first speaker, Dr. Ernesto, to give his keynote address.
Good afternoon, ladies and gentlemen. I'm Dr. K.P. Reddy. Dr. Ernesto said he'll introduce himself, so I don't think we're going to do any introductions. Thank you.
So, hello everyone. My name is Ernesto, and I'm an ophthalmologist from Salamanca, Spain. It's a little town next to Madrid, and I own a private practice in this town. It's for me a great pleasure and a great honor to be here with you all, and I would like to thank All India Ophthalmology Conference organizers for inviting me to this amazing town, and a special thanks to Star Surgical for selecting me to give this conference about vision ICL as a primary refractive procedure. So, let me briefly introduce the ICL. The ICL has been over 20 years in the market. Actually, the first ICL implant was in 1993. We have had toric ICL since 2002. And I think the best improvement in all this long life of the ICL was the launching of the ICL V4C back in 2011, which supposed a big decrease in the risk of cataract associated to ICL, and also made us surgeons avoid the need of a peripheral iridectomy in our patients. The dioptric correction range goes up to -18 in myopic patients, +10 hyperopic, and up to 6 astigmatism. And basically, the indications are any patient who has an anterior chamber depth wider than 2.8 millimeters. So back in year 2000, when the ICL was introduced in the market, this market was dominated, the refractive surgery market was dominated by excimer laser, and the surgeons offered the ICL to these cases in which laser wasn't suitable or wasn't the best option. So basically, ICL was left for laser leftovers. And this is basically the currently accepted indications for many surgeons today. We are speaking of high-range myopia, not suitable for excimer laser, usually above -8, that is accepted. Nowadays, we're bringing this down to -6. High-range hyperopia with a suitable ACD, high astigmatism, thin corneas, irregular astigmatism, such as keratoconus or post-radial keratectomy patients, and when we have a mild to severe dry eye. But take a moment and imagine a different scenario. If ICL had arrived in the market before, had preceded laser excimer. In this scenario, we would be treating a patient with ICL, which would have replaced the radial keratectomy back in the 90s. We would have really good feedbacks from our patients. We would be operating -1, -3, -18, +6, any refractive range with the ICL. And then back to this newer scenario, the laser excimer arrives in the market. So what would be the actual indications for laser excimer surgery? When we have a really good feedback, we're implanting ICL in every ACD suitable patient. Why would we bother buying really expensive machines? Why would be considering operating on a cornea? I think these are interesting questions that we should take a minute to think about. But coming back to the ICLs, I would like to address the possible issues we can find with them. In my opinion, these are 3 different issues. The first one is the fact that we are talking about an intraocular surgery. And this means there's a risk of infection which is extremely low. We're talking about a rate of 1 out of 10,000 cases. And if we compare to other refractive surgeries, such as lens exchange with implant of intraocular multifocal lens, it's 1/20th the risk of this last procedure. So we are talking of a very minimal risk. The second issue is the price. The ICL is more expensive than excimer lasers, than most of excimer laser procedures. But in my case, it's a similar price to a lens exchange with multifocal lens implant. When I have to explain the price to my patients, I usually compare it to cars, okay? We all know cars have 4 wheels, an engine, and we get from point A to point B. But there is a very wide range of prices in these cars, and it has to do with the quality of the product. So when we inform the patient, they get the feeling that they're getting a quality product, which they are. And then the third issue, which I think is really important, especially for surgeons, is the sizing of the ICL. This means getting the right size for our patients. And I think this is one of the great fears of beginning surgeons when they have to face, once they have decided it's a great product, they have to face the patient and try to choose the right size of ICL, which usually we talk about perfect vault between 250 and 750 microns. In my opinion, is acceptable from 100 microns to 1,000 microns. But that doesn't mean that below or above that, we have to exchange the lens. I want to share with you 2 cases from my practice. This is case 1. It's a patient who was operated in 2008. So it was a B4B lens without central flow. Initially, the vault was right above 100 microns. The vision acuity was really good. The patient was very satisfied. But after a few years, that vault came to 0. I mean, when I measured the vault in 2012, we had a 0 vault, as you can see in these images of OCT. We have been taking care of that patient ever since, and now she's 52 years old, and she still has a vault 0. There is no central flow. There is no cataract. We are not going to exchange this lens. In the other hand, we can show the other case, which is patient operated last year with an EVO, which you will have available, EVO Plus. You will have it available in India in a few months. With central flow, the vault was over 1,200 microns in one eye and 1,100 in the other. But the anterior chamber depth is 3.7, so we don't need to exchange this lens either. Basically, you have to feel the lens in the eye, and then you decide if you exchange or not, if that was the case. But we don't want these cases, these extreme cases. We want to avoid them, so I'm going to give you a few tips, considerations about how to make a more accurate ICL sizing, which I think is really important. We all use the OCOS device, which is offered by Star Surgical. I think it's a great way to measure the ICL. It's based on the white-to-white measurement and, of course, of the anterior chamber depth. And with this device, the accepted rate of exchange of ICL is 1 to 2%, which is extremely low. But I think I have to encourage a few tips about how to measure the white-to-white. In our case, we always measure it with an electronic device. In our case, it's the IOLS 700, and we also measure it too with a manual caliper. And that is, for me, the right measurement, the manual caliper. But I always like to know the correlation between the machine and the way I measure the white-to-white, because if 3 of us measure white-to-white with a caliper, I'm sure there's going to be little differences. So it's very important to always be the same person measuring that white-to-white, always the same machine, always the same caliper. In my case, the measurement we get from the IOLS is 0.1 to 0.2 more than my manual measurement. we we've been using this ever since, and the rate of exchange was 1 of every 50 lenses. That is 2%. But we thought that if the ICL is placed in the sulcus to sulcus, we should try to measure the sulcus to sulcus. So we started using a UBM device, in our case it's the Quantal medical device. At the beginning we used the immersion system, and I had to stop using it because it was really uncomfortable for the patient, take a lot of time, it was dirty. So we got this probe, which is a direct contact probe. You can do it with the patient sitting, and you get very accurate results after a few patients. It's easy to learn, so we can get a very accurate measurement of the sulcus to sulcus. In our study, we have been doing this for 180 cases. We can see that the sulcus to sulcus measurement usually is between 0 and 0.5 millimeters less than the manual caliper measurement of the wide to wide. So in these cases, between 0 and minus 0.5 millimeters less than the wide to wide, we wouldn't change the AIOC's preferred lens size. But if we get, which sometimes happens, it's not very usual, but you can find patients with different correlations between wide to wide and sulcus to sulcus. When it's less than more than half a millimeter, you have to change one size down the AIOC's elected size. And if it's bigger, if the sulcus to sulcus is bigger than the wide to wide, we're going to get it one size up. In general, we can say that the elected ICL should fit the sulcus to sulcus size plus 1 to 1.6 millimeters. You have different sizes of ICL, and the one that fits there is going to be the best option. But usually we have not only one ICL size, but 2 that can fit in a patient. So although we can find, maybe we don't find the best bolt, if it's good for the patient and it's good for the surgeon, you don't have to change anything like that. So now, once we have overcome the issues, let's go to the good part. We're going to see the advantages of the ICLs, which are a few. We're going to have an optimum visual quality and contrast sensitivity. This has been studied in many papers and based on the MTF study, and the visual quality is much better, comparing to LASIK procedure. I'm talking about LASIK in this case. But in our practice, we have some cases at the beginning in which one eye was operated with LASIK and the other one with ICL due to the quantity of diopters, and always the patient reported better vision with the eye operated with the ICL. The second important advantage is the fact that it's a reversible procedure. This may seem not very important for us, but it certainly is for the patient. I think this is a key word we have to keep in mind when we inform about the advantages of the ICL to our patients, because, in my opinion, it's going to make them decide for the ICL due to this characteristic. And the third important one is that it maintains the corneal and the ocular structure. There is no risk of retinal detachment compared to LASIK because there is no vacuum, and there is a cornea that is going to be untouched for the future. Now we operate in a 30-year-old patient, but 30 years ahead, he's going to have cataract, he's going to want lens exchange because he doesn't want to wear close vision glasses, and then it's not the same to have a LASIK procedure in the cornea than to have an untouched cornea. We're going to calculate much better the power of the lens to put, and we're going to have a better quality of vision if we place an ICL rather than a LASIK procedure. We are not going to create any dry eye. All these patients with problems with contact lenses are going to be a lot happier with an ICL than with a laser. Maybe not at the beginning, but in future years. Apart from these 4 main advantages, we can find very high accuracy in calculating the lens power. We have no refractive surprise with ICL, very, very rare. It is a very simple technique. I mean, at the beginning, you are with a sane eye, a normal sane eye. You have to put an ICL, and we're all nervous, but it's very easy procedure, very simple technique. We can use sedation. We can't with the LASIK, and this is important in this difficult patients or difficult facial structure of a patient, and the recovery is as good, at least, as with LASIK. And maybe we can enjoy the advantages of a multifocal ICL in not many years ahead. So, if we see all this big list of advantages, we ask ourselves, why can't all refractive patients enjoy ICL advantages? And the answer is clear in a clinic. They can. If we take a look at these graphics, these graphs, they're very simple, but they're very significant. This first one is 2002, in which we have 94% of LASIK surgery versus the 90% of ICL surgery in 2016, compared to the 8% of laser excimer. And how did this happen? Because it's a strange turn. Just a minute. The very first patient I operated on was, the very first session was 8 eyes, and one patient was a -3. He wanted to be a police officer, and I had to take the glasses away. The best option was the ICL because he had a really thin and irregular cornea. So we decided to put an ICL, to implant an ICL. And I was surprised the next day. I was nervous. It was my first ICL surgery. What a happiness, what a feedback we got from this patient. So my thought was, if I can put an ICL in a -3 with an ugly cornea, why not in a -2 with a nice cornea? So along the last 15 years, the patient base we have expanded the patient base to whom we have offered the ICL as a surgical option. When a patient arrives in the clinic, we take our time to explain the different procedures. We take our time to see the advantages. We take our time to see the issues. And most of the patients choose the ICL as their preferred procedure. In fact, the word of mouth travels quick in our town, and many patients come asking for an ICL rather than refractive surgery. We have changed the trend. I mean, the ICL is no longer for the leftover cases, but now it's the main dish. So in conclusion, well, we focus more on the ACD rather than the corneal thickness now. So in conclusion, we're going to have great patient satisfaction in challenging cases. We're going to have great patient satisfaction for every refractive suitable patient. We're going to have great satisfaction as surgeons, a low complication rate. It is a reversible procedure, and we have preservation of cornea for the future. In summary, ICL is a premium option in refractive surgery for all ACD suitable patients. And that's why it's a main choice for all suitable refractive patients. And this concludes my presentation. Thank you very much for your time. And I would like my personal experience to encourage you to consider ICL in the future with your refractive patients. You won't be disappointed. Thank you very much.
Thank you very much, Dr. Ernesto. Could you please? Can I now invite Dr. Swapna Nair, please, for the next talk?
Good afternoon, ladies and gentlemen. So now we have gone through the major indications for an ICL. I'd like to look at this procedure in general. So, I mean, whenever you're looking at a phakic IOL, what characteristics are you expecting in that IOL to make it suitable for implantation to the human eye? So, first of all, where do you want to implant it? Now, you have many options. You can put it in the angle, you can tag it onto the iris, you can use a sulcus, wherever you want. But wherever you're putting the lens, it should be sized in such a manner that it's going to stay there uneventfully. I believe the sulcus is a natural niche for an ICL, a phakic IOL for that matter. Because when you put something in the angle, you always have the glaucoma people, alerted, because you have very important structures lying around, trabecular meshwork, and once you damage them, there's no going back. You tack something onto a vascular structure, a highly pigmented structure like the iris, and a dynamic one at that. So again, you have a higher chance of pigment dispersion and other complications. And these two positions are way too close to the corneal endothelium. The sulcus, which lies snugly between the iris and the lens, it's a natural space. And when you keep an intraocular lens there, provided that it has a natural vault keeping it away from the anterior surface of the natural lens, that is an ideal place protected by the iris and keeping it away from the corneal endothelium. So, and it's pretty close to the nodal point of the eye, which is another important factor, which reduces the aberrations and provides a great refractive outcome. Now, coming on to that, when you're placing such a foreign body in the sulcus, it has to remain there. And it should not be turning around, especially in cases of a toric phakic IOL. So, now the zonules that flank the sulcus make sure that when the plates of the phakic IOL go in there, it cannot be disturbed very easily. So in case you want to change the position, you'll need to tuck out the ICL and then put it back inside, and then again go to the opposite pole, pull it out and push it back inside. So it's not like rotating an intraocular lens where you can just dial it around. It needs an effort which makes sure that stays in position. Now, what about the surroundings? Here you can see that when the lens is being implanted, the material is so thin and pliable that it does not disturb the iris at all. It simply just goes into the sulcus so very easily. So this is what we are looking at. So we need something thin that is strong as well and does not disturb the surrounding tissues, including the lens, natural lens, as well as the iris. Now, when you're putting it in the sulcus, another thing is the spacing should be such that it's neither too close to the lens, nor is it so tented up that it moves the iris up and compromises the angle. Now, this can happen if it has a natural vault between the optic zone and the plate haptics. And secondly, if the sizing is good, I think Dr. Juarez has already talked about his technique of sizing. I still use the manual calipers, the digital ones, which give me very accurate results. And I feel that the IOL master also sort of overcalculates the size of the white to white. So if you are consistent with your white to white, then you will get consistent vaulting, and that makes sure that your angle is safe. So is the natural lens. Now, the phakic IOL should be an adjuvant in your armamentarium to refractive surgery. So when you have situations which are unsuitable for refractive surgery, even those should be taken up by your phakic IOL. So this happens when you have some sort of an abnormal cornea, like a cornea that's too steep, or you have a high posterior vault, or you have a cornea that's scarred, or you have a range which is way too beyond your laser, or maybe something like a keratoconus patient. So in all those situations, you can always implant a phakic IOL where you cannot do with a laser-based corneal surgery. So these are the situations that the phakic IOL should cover, and the ICL, which has a range from plus 10 diopters for hypermetropia to minus 20 diopters for myopia, the spherical equivalent, that is a pretty huge range which covers all sorts of patients that you want to deal with. Now, again, when you come back to your material, just as it's easy to implant, it should be as easy to explant as well. Now, this is particularly important because there are rare cases where you may have sized it wrong, or where some other event, dissatisfaction to the patient, might want you to remove the ICL. I have just done it in one case where that was one of the first cases when the vaulting was too high. I was just learning how to size. And you can see how easily it comes out without even taking a single pigment from the iris, and how easily it can be pulled out through the same incision without extension, the same incision that you put it in through in the first place. So such a traumatic nature of the material and the IOL is very important. You should be confident that what you've put inside you can take out without disturbing any of the surrounding tissues. Biocompatibility, both with the natural lens, and here you can see a phakic IOL, though it's an off-label indication, in over a pseudophacos. So in both these situations, you don't have formation of any membranes or any biofilms, any sort of excessive inflammation. So all this is made sure because proteins don't adhere to the surface of the phakic IOL. So this is very important when you're placing the IOL in a patient who is young, has a long lifespan. You don't want a pacification of the visual axis. This is because of formation of fibronectin film around the collamer material of the ICL, which prevents adhesion of proteins to it. So now this is a picture which compares protein adhesion to a hydrophilic acrylic lens, an intraocular lens, along with the collamer hydrophilic ICL. And you see the amount of protein deposition is very vastly different. Now, when you want to put in a phakic IOL, you should make sure that the incision you use does not induce any sort of additional refractive error. So this, which goes through 3 mm to 3.2 mm, which is what I use, is a pretty good incision, and it's self-sealing as well. So this is another parameter that should be applied to which was not actually there for all those rigid phakic IOLs that you needed to tag onto the iris, or those were angle supported. Now this is a huge change for the sulcus-based IOLs. Now, minimal instrumentation, minimal amount of chemicals that you're pumping into the young human eye is very important. So all you need is an injector, a manipulator, and saline as well as visco in the name of chemicals. Complications produced by this phakic IOL needs to remain low. Again, you're dealing with very young patients who have no other morbidity besides their refractive error. You need not induce any more. Cataracts happen when the lens is not biocompatible, when it's sitting on the natural lens, or when you are not able to consistently size this. So all this does not exist with the star ICL, and so that prevents cataract formation, reduces it to a large extent. Endothelial cell loss is virtually absent because it is well positioned away from the cornea in the sulcus. It's around 6% over a period of 5 years, and some studies say even over a period of 8 years. RD, which is a bane of any form of intraocular surgery in a high myope, is also most often due to the primary pathology and not due to this particular intraocular surgery. And I also have a patient in whom an RD happened following trauma in an ICL implanted eye. And that's patient, keeping the ICL on, my VR surgeon was able to perform the retinal detachment surgery as well. So it is not an impediment to any other surgery the patient may need because of any other problems. So consistent results, both refractive as well as surgical, compatibility with surrounding tissues, and freedom from complications are some of the ideal aspects I would look in any phakic IOL, and the star ICL definitely suits the bill. Thank you very much.
So, thank you, Dr. Swapna. And we now next go on to Dr. Sanjay Chaudhary, who's done hundreds and hundreds of ICL, to share his experience on ICLs or the phakic.
Okay. I'll be talking about 10 pearls of phakic IOL surgery. So 10 things which you should keep in mind when you're doing an ICL surgery for a successful outcome. So,
What is this? The next session?
think you got it now. Yeah. Okay. So the first pearl. I'm not going through the whole procedure. I'm just going to give you small video clips of what I feel are important points that help you discriminate one versus the other. First pearl, when you are loading an ICL, you have an option of loading it with a foam tip applicator. And this is how I'm showing you. You're loading it with a foam tip applicator. And there are two movements. You can twist your wrist to the right, like the one I'm showing you right now, or twist your left to the left, anti-clockwise. And anti-clockwise gives a better control, this position now. A little twist to the left is very minimal. It gives you a better control to put the ICL into the cartridge. It was a very, very short span of time. When you go home, you can try it out. And some people are very comfortable with the forceps. I have used forceps for years, but I still do feel that the foam tip applicator is a better way to put an ICL. Now, what happens when an ICL opens or tends to open sideways? You're injecting the ICL and somehow it's not going in right at this time. It's opening sideways. So when you're about 2/3 in, you judge, turn the tip of the nozzle and manipulate it in such a way that the final outcome is that it opens straight in the position you want it to open. In case that is not happening, it's useful that you take out the ICL before it opens into the eye, because taking out not though difficult, but it's possible. The next situation is if things went out of control and the ICL did open inside out. Like in this case, the ICL suddenly veered to one side and then it was out of my control, it opened upside down. Now what you have to remember here, that here you are a refractive surgeon, not a phacosurgeon. You have limited space there between the crystalline lens and the endothelium. And cataract surgeons are used to rotating the IOL within the eye, but don't try this here. This is what I'm trying to show you. Don't try this here, because here the space is very limited. Any attempts will really damage the endothelium and possibly the crystalline lens. What Dr. Sapna showed is that if you can just hold the ICL with any forceps and bring it out, it's very simple through the same incision. Now, when you bring it out with a normal forceps like the McPherson's, you would want to hold the ICL at the thickest point. And the thickest point is the junction of the optic and the haptic. And to have an easy access to the thickest point, you may dial the ICL a bit. And at this point, the forceps is closest to the optic haptic junction. You can hold it and bring it out. But if you have better designed instruments, like the one I'm using here, this instrument was actually designed for holding an IOL and cutting it within the eye. I found it very useful, and the grip was wide and strong and non-damaging. And with this, I could just hold the ICL anywhere in the haptics and simply pull it out. I have become very fond of this kind of a thing, and in the subsequently 2 more cases, I used this instrument to take out the ICL. What has happened? Where is that one? What happened? तो यही just a minute. Okay. So, the next important pearl is pearl number 4, that once you have implanted the ICL in its required position, it is very important to thoroughly remove the viscous. So to thoroughly remove the visco, I use the bimanual IA system, and here you would see that I am placing the mouth of the irrigator over the central hole and using the aspirator's tubing to cover the other hole so that I can push the ICL down the central hole under the ICL, and it comes out from the side of the iris. So I'm very confident after doing a good 1 minute of irrigation aspiration within the chamber that I think I have removed the visco in totality. But if you can't remove the ICL visco under the ICL, this is what you will see in the next picture. This whitish stuff on the crystalline lens is the visco, which you see on the first postoperative day in case the visco is left behind the ICL. Now you don't need to panic, leave it as such, keep a track on the IOP, and this, as the aqueous movement continues slowly and slowly, this visco will dissolve and come out of the eye in about a week or 2 weeks' time. Now if you have a situation like this, where you have a astigmatism of 0.75 with the rule, you may decide to use a toric IOL or you may decide to use a spherical IOL. I prefer the spherical IOL, and I give an incision at the steep axis, which is at 12 o'clock. I implant the ICL through the 12 o'clock position, and then I rotate the ICL in the 3-9 o'clock position, because that is where, can I have just a minute more? Or rather 2 minutes. That is where the 3 and 9 o'clock axis is located, and you can dial this lens very comfortably by a bimanual technique and bring it into position and then tuck the lens in this position. Now, just comparing a coaxial to a bimanual irrigation aspiration, if your incision is 3.2 and you are using a coaxial like this, in my case I have a coaxial which is 2.2, there is going to be a lot of leakage from the wound, from the main incision, and along with the leakage there would be the iris prolapsing out of the incision because the AC is now shallow, the iris is very close to the incision, and with the egress of fluid it keeps coming out, and if you keep pushing it back you will land up with a floppy iris and more problems. So a bimanual technique is a more controlled technique where the chances of the iris coming into the incision is less because you're going through the side ports and the cannulas are fitting snugly into a 1 millimeter side port. However, it does not mean that if you are doing a bimanual irrigation aspiration, you would not have an iris prolapsing from the main port or the side port. Because the AC has become shallow and the iris is very close to the incisions, it can get tucked or involved in the side ports. Don't use a manual instrument to deposit the iris at this stage. Carbocol does just fine. You put carbocol, the pupil constricts, and the iris just comes out of the incisions, and it gives you space to continue with your surgery. Pearl 8, in case of hyperopia, you have to remember, number one, you should have the right ACD. That is a mandatory thing, which is comparatively less as in cases seen in hyperopes. 2, a hyperopic ICL does not have a central hole. Only myopic ICLs have a central hole. So if you are using a hyperopic ICL, then you would need to do a peripheral iridectomy, PI. Another thing I wanted to show you in this, that there are 2 types of tuckings which I use. One is the single hand tucking, which I am showing you right now, of the haptic under the ICL, and another is a bimanual tucking. which becomes very useful, comes in handy when you are tucking the distal haptics, to which you have comparatively less access, especially when the pupil is coming down. So now watch the tucking with the bimanual technique. With one instrument, I hold the ICL along the optic-haptic junction, support it there, pull it back, and with the other instrument, I comfortably tuck in the haptic under the iris. See this now. So this is the bimanual technique. And in case you have to do a peripheral iridectomy, there are several ways, but my preferred way is the vitrector peripheral iridectomy, and you could make one or two clean-looking, punched-out iridectomies. But there's a catch to it that if your control is not good, you could land up in a situation like this with a large iridectomy. And the last, or the 10th pearl, is that you get very good results in a toric ICL implantation with your manual techniques, the bubble marker, bubble axis marker, and all those techniques. But in case you have a digital axis marker, it helps, because if you can project with the digital axis marker and your projection with the digital axis marker coincides with your manual marking, you are doubly sure that you are in the right position and you would get the best results. Thank you.
Thank you, Dr. Sanjay. After giving all the practical tips, and maybe we had the discussion in the end. And now I invite Dr. Somshila to give a talk on her results of Phakic IOLS.
A very good afternoon to everybody, and I'd like to thank the organizers to invite me to participate in this session. I'm actually going to be talking about the visual and refractive outcome of the new design Phakic IOL. I don't have any financial disclosures, but the text of some of my slides have been provided by the company, and that's what I have. So just talking about Phakic IOLs, you know that we used to have several designs, including the anterior chamber Phakic IOLs, which could be iris fixated, and the angle supported Phakic IOLs, which were made by several companies. Many of them we're not using right now, and maybe some of them might come up in the future. But currently, most of us seem to be using the posterior chamber Phakic IOL, which is a vision implantable columnar lens, which is made by Star Surgical Company. And this particular lens, we have been hearing about its advantages. It's basically the columnar material that I think that has a sort of a really good platform for us to use for these patients, because the post-operative pigment deposits are not seen. It's very biocompatible, and it seems to be giving good optical results for our patients. So the current version, as Dr. Chaudhary just so elegantly highlighted, is a Vision ICL which has a central port, and this actually obviates the need for PI. So the previous versions we used to do our PIs and have the kind of problems with PIs that he just showed in his surgical tip number 9, I think. So that is not there. That's obviated now, and the patient's visit having to come, if you want to do a YAG laser PI, a little bit ahead, and all that is gone now. So you don't have to do a PI most of the time. And also the EVO Plus is what the company is calling its latest version, which is not yet available in India, but maybe soon, later on in late summer this year. So it has an increased optic with an expanded dioptric range. And the increased optic is ranging from 5 to 6.1 millimeters and available in all its spherical powers. So what is the idea of increasing the optic size? So we all know, and size is slight cause for concern for those of us who use the ICL is the problem that the patients complain of halos. We know they will, because the optic diameter is slightly smaller for these patients, and many of them, of course they're all young, and many of them would have a mesopic pupil size which would be definitely a little bit larger, and all the patients come in and complain of halos very early post-operatively. but slowly they probably get acclimatized, or the result improves with time, and halos is not the top complaint when you see the patient later on, but early on it is a complaint. So the increasing the diameter of these lenses will hopefully enhance the visual quality in our younger patients, or those who have larger pupils at night, or those who do a lot of night driving. And how does this happen? In two ways. One is that there is a corrected area and an uncorrected area, obviously. So there is a light that is passing through the uncorrected area, which causes quality of vision issues. And the second is that the higher order aberrations induced by the prismatic effect at the edge of the lens is also obviated if you have a larger diopter ICL. So the EVO Plus design now has a larger diopter in these powers, but not in the really high powers at this point. So there are a few published studies, and this lens is already in use in the European market. What this particular study, which was published in JCRS by Vincent's group, says that they looked at the optical quality and compared the results between the same type of polymer used for Phakic IOL designs, which included the newer version of the Star ICL, that is the EVO Plus. And they looked at multiple parameters in the patients, and they looked at sizes of the pupil at various sizes, 3, 4, and 5 millimeters, and saw how these patients were performing when it was in good condition, in driving situation, and in mesopic condition. And what they actually found, that there was really not much statistical difference in terms of the higher order aberrations, but the EVO Plus lenses seemed to perform better for these patients, and they had excellent quality of vision in terms of the mesopic pupil size. So there is a presumed benefit. It's not, when I went through the entire article, it's not concrete and crystal clear, but maybe the sample size should be larger before we come to that. So the age range in this particular study for the young patients, and we know historically that young patients have pupil diameters under night driving conditions of which would be more than 5 millimeters. And in their study also they found the same results. And they also found that the patients with higher pupillary sizes had more risk factors for night vision disturbance, such as halos. And they also found that for these patients, when we used the expanded pupil size ICLs, the patients had lesser night vision problems and halos. So that was a positive benefit that they noticed when they studied their patients with the new ICL. So the specifications for EVO and EVO Plus include both in the spherical ICLs as well as in the toric. And what it says is that these are the current optical diameters on your right-hand side, and these are the newer optical diameters for the same lens power on your left-hand side. And you have a pretty good, almost 3 millimeter increase in the optical diameter that correlates to a lot of better improved function for the patient in terms of its performance, except for the higher powers where there's no increase in the pupil diameter. So up to -14 range, you do have an increase of almost up to 0.3 millimeters for these patients. So based on the results that we have, it seems like EVO Plus Vision ICL, because of its larger optic design, you can reasonably expect that it's going to enhance the quality of vision for the patients, in the sense the larger optical diameter will, with its increase, since it's present both in the toric and spherical ICLs, are likely to decrease the problems that the patient can have of reduced night vision and glare and halos and the optical side effects that they face. Of course, this has to be validated by further studies, and this has to be validated maybe when we get our lenses here by us as well, but it's extremely promising, and I think this is a good surgical innovation that they have come up with. So this is some of the reference I looked at for this particular talk. Thank you very much.
Let me invite the next one. Yeah. So I invite Dr. Khokar to summarize basically the whole thing, that is Phakic IOL sizing, because the result, the crux of your surgery depends upon the size, which has also been emphasized earlier.
Last talk, but last but not the least, don't put it upside down. If your sizing is wrong, I think that's the only time you can get in trouble. And sizing, so you don't have too many sizes. There's just 4 sizes you have to go. It's something like when you're going to the market to buy a ready-made shirt, there are just 4 sizes available. So your sleeve might be good, your shoulder might be good, your collar might be tight. So you have to find out the ways and the parameters, how they can fit into that. It's not that you go into the tailor shop, you pick up a cloth and get your things altered, stitched according to your need. So we just have to manipulate. And why they have just only four sizes? I'm going to be talking about that. What is the size? That's the size of the lens from edge to edge, and that has to correspond to the sulcus to sulcus. Rather, my friends from Europe call it sulcus to sulcus. I love that, but I still call it sulcus to sulcus. Okay. Second, the vaulting. So vaulting, when I put a lens flat on the surface, the hump which is there is called the vault. How much it's rising from the anterior capsule is the vault. So even if you want to put the lens flat all the way down, it will not go because these lenses have inherent vaults. So if your sizing goes up or down, your vault can go higher or lower. So these are the two things which I'm going to be discussing for the next 10 minutes. Okay. So when you select IOL, ICL, the two things you're looking at. One is the power, which power to give, and the second is the size. Power is simple because you do a good cycloplegic refraction, you do a duochrome test and pick up the power. That's not a problem. The second one is the issue. So your size of the lens will depend on your white to white. But that is sulcus to sulcus, right? And there's so many ways you can measure it. So how does the white to white extrapolate to the sulcus to sulcus? Different study quotes different sizes, but by and large, it's about 0.42 millimeter bigger than the sulcus to sulcus bigger than the white to white. So you take that white to white and add 0.42, and you should be almost there. But all the eyes are not same. There could be anatomical differences at the back. There could be undulations at the anatomy, and those anatomy could be different. The pupil might not be in the center. It might be more on one side. The iris structure might not be the same in all the eyes. So if you see from the back, that's what a sulcus looks like. So you can have these corrugations. There could be sizing difference, and there could be certain places where you have openings and the haptics can get stuck there, and you might get in trouble in these patients. But that's very rare. So this was the biggest study which was done by Pope et al., which was published shown in American Academy in, I think, 2002, in which they've taken big data measuring the white to white, the sulcus to sulcus, and angle to angle. What they found out was there's a difference. If the white to white is 11.7 at mean, sulcus was 11.9, and at the back, the angle was 11.9, and the sulcus was 11.2. What they did was they used a UBM to measure it, actually. So the basic flaw in the study was that if you take a 50 megahertz UBM, you have to have 3 pictures, and you have to make a collage and then measure. If you're taking 3 pictures, there's always a chance of error because there might be overlap. So you can over or under pick up the size of the sulcus. Whereas a good thing to do is that they should use a 35 megahertz, which can take a straight picture from angle to angle, sulcus to sulcus. But this study had a fault because they didn't use 35 megahertz, they used a 50 megahertz probe. So that was the issue. So they had to take 3 images and put them in a collage. At my center, when we used to use OpScan 2, which has become obsolete, but that was one of the best mechanisms of picking up the white to white because it's a scanning slit. So it starts scanning from the clear cornea and till the time it ends to the other side. That is where the Schwalbe lines come. So that was one of the most accurate system, but I think it's nobody using and it's not available. They're not giving any new machines now. OpScan 2 is gone. So short of that, caliper is the best. I think I use caliper to measure my golf balls, and they're pretty accurate there. So this is the one which I think people should use. You have Pentacam, but Pentacam as such gives you a little higher. IOL Master also gives you a little higher. The only instrument which is closer to the caliper is a Lens Star, which is by Alcon company, and in that, if you can measure white to white, that's the closest to the OpScan which you used to get earlier. So even if you're using OpScan or any machine, you have to keep validating the data on that. So you have a caliper, and you keep validating every 100 patients. After that, you should actually go and take the crystal balls, which are of the known size, and you try to measure and see how they're working in your hand. So the caliper also has to be calibrated because they can also lose their grips and they might become a little wider. So if there's a discrepancy in both the eyes of more than 0.5, the lens size might change. By and large, if it's possible, but it's not a very common thing to have different ICL sizes. But in case you're very sure, you double cross-check and thrice you checked it, and still you're getting a discrepancy, you can have different lenses. But by and large, we should be putting the same size lenses. So you look out for any cornea problems, which there could be a pterygium or a pinucula, which can cause an issue. Okay. So AIOC cannot measure your sulcus to sulcus. So even if you buy that one, it's not going to help you there. It might help you in picking up the vault post-operatively, and we'll be discussing about that. So these are the machines which I have my center, and we use it. We use OCT for measuring the the size of the vaulting. Now, these are the 4 sizes in a myopic lens. You have 12.1, 12.6, 13.2, and 13.7. So how do you expect all the eyes to fit into this? It's not possible. So there's certain eyes for which the ICL is not meant. So you have to be careful, because you don't want to burn your fingers there, because you might get into medical legal hassles also. So at the last end of this thing, I think you'll be clearer. So this was a study in which they'd taken thousands of eyes, in which the normal population aging from 10 years to 80 years, they'd taken healthy subjects and checked the right eye, left eye, gender, and they found out this was the outcome, that 99% of these eyes were falling into 11.4 to 12.5 for males and at 10.7 to 12.5, which actually will cover 90% of your ICLs in a normal healthy population. The big cohort, they had done this one. So why I'm harping upon that of the sizes, because if you put a smaller lens, it will be having a shallow vault, the more chance of cataract, more chance of lens rotating and cataract. And if it's a higher vault, which used to be earlier, that you can get glaucoma. So these are the 2 things you are scared of, actually, right? Okay. So you can assess it on the slit lamp. This was the old chart in which the red was dangerous zone. Like, you don't want to have a vault which is 100 micron, but this was not with the V4C. You saw the first presenter who said that even 100 micron is good enough for that, because there's a flow which is going through the opening and it might not cause cataract. Well, that's okay, but I think this is more important. Now I would like to have my vault a little higher. I don't mind if my patient is 1000 volt. I won't be unhappy. If my vision is okay and there's no surprise in the power, I'll prefer a 750 to 100, a 1000 micron rather than having a 250. And the reason for that is, and these are some pictures which you can make out. Okay, all right. In fact, I'll go. We have time for this?
Yeah.
Yeah, okay. So this is an optimal vault. You see the corneal thickness, you can see according to this is about a 500 microns, right? This is a high vault. You see, this is cornea, and that's almost double. So it's about 1000 volt. And these are all old lenses, because you can see the PI is there. Now this is a 2/3 vault, it's a little shallow, and this is almost negligible. It's not even 100 there. So when you have a patient with a low vault coming to your follow-up, it's mandatory for you to dilate this pupil and see the periphery of the lens, because it's a myopic lens, so it's going to be thicker in the periphery. So the peripheral touch might be there, and you might have a cataract. That does not mean that you should jump and take out the lens, right? So I'll just show you some videos of that. And you can do the same on a OCT as well. Now this is one simple test which tells you what happens if your size is more, if you put in a big lens. So what you need to do is, you just see this one. This is a 12.6 millimeter lens, right? And by mistake, you put in a 13.6, right? So this is what will happen. I'll go it again. See this and see this, all right? So it's gone up. So what is happening here is, and this is a graph, you get the force in the vault, and which you can make a regression statement out of that. So each 0.1 millimeter rise, with each 0.1 millimeter change, you can have 5 milligram force coming, and a 0.11 millimeter of rise of the vault. So if I put a lens rather than 120, rather than 115, I put 120, I'll have a vault which is increased by 500 microns, which is not bad actually. So why are we talking about higher vault now? Because this study, which was done with V4C, they found out that over a period when you follow this patient, they are losing the vault. And what they said was that they're losing the vault because there could be change in the support in the sulcus over the period, or could be a change in the form of the ICL. Nobody has proven this thing, but these are what they're talking about. I mean, these are hypotheses. And the lens rise. Now, each year, according to them, they lost about 28 microns. So if you have a 700 micron, it's good for 25 years, which is a good period. And if you have 400, it's stable for 10. And this was basically with a V4C, that's what they talked about. So after this study, I've started increasing my vault a little higher, between 750 to 1000 micron, and they've been pretty good. So what is the aim is to aim for the greatest possible postoperative vault without changing the power. So if your power goes by 0.5 or plus minus 0.5, that's not what you want. So you calculate the power and go for the sizing on the little higher side and take one size higher in these ones. So I'll give you an example. This was a patient which was operated on 6/8/2008, first eye on 6th and second on 9th. Now this patient has come to me after 6 years. Okay, now it had 11.7 with a 330 ACD. Now what I'm bringing into picture is a ACD factor. So ACD also plays a hand in finding the size. So white to white and the ACD is going to make you equation which is going to make you safer. So this ACD I put a 120, I could have got 126. I could have got a 12.6 in this one. So see what happened. This patient is falling with me with about a 200 micron, and that's a cataract she developed. And this cataract is there for the last 3 years and has not changed. Every year she comes, I dilate and take a picture. She's 6'9", she doesn't want me to do anything. Neither I'm too keen to go into the eye because patient is happy. And if this was a V4C with the opening in the center, I think I would have been much happier. Maybe this thing might not happen because there are 2 holes on the side also. So maybe the circulation would have been better at that time. So the white to white and ACD both come to the picture. Now, these are the last few slides. Now, ACD can be picked up from 2.8 to 4.5. If you have less than 2.8, your machine, the computer is not going to take the data in. So you can't get the lens for that eye. And if it's more than 4.5, still you can't do it. The question, the chamber is deep, it's more than 4.5, why shouldn't you not get the lens? Because these 4 lenses are available and you can't tailor-made the size of lenses. So you have to try to fix it. So these are the patients where you should say no. And the white to white, when you say it's between 10 and 13.5. So using these 2, white to white and ACD, I've come out with a small formula. So if the corneal diameter is less than 10.5 or more than 13 and ACD is less than 2.8, no ICL for these patients. You tell them, sorry, we can't do that. Right? Okay. Now you have 11 corneal diameter, 11.5 and 12. ACD less than 3 and more than 3. If it's less than 3, you can put a 12.1 and you will have a high vault. And if it's more than 3, your vault will go down. So the smaller the eye, the vault will be higher. So you can manipulate using your anterior chamber depth as well. So if the white to white is 11.5 and ACD is less than 3, if you want a higher vault, you can go for 12.6. If you want a little lower vault, you have options now. So this is where you have to decide what you want for your patients. And especially if you've done one eye and the vault is high, in the other eye, you know that you can go step down. And this actually, logically, you can derive from this and you can pick up this for your work. And similarly for the 12 millimeter and for 12.5, again, it's a 1. So if it's more than that, you're not putting an ICL in these patients anyway. So if you're using a toric, you tend to use a 0.5 extra. So you use one size extra if the chamber depth allows. And if you're planning for a high vault, please add 0.25 extra in your myopes and 0.25 diopter less for the hyperopes, because since the lens goes a little anterior, the plus lenses become more effective and the minus loses efficacy. So you can add this 0.25 factor, which we have been trying for the last couple of years, and we are pretty good. So even if the vault is high and the refraction is on target, I'm not going to change these lenses. So with this little formula and little talk, I think I'll close and open to questions.
Thank you. Thank you, Dr. Coker. If you don't mind staying there.
Sure.
And Dr. Ernesto, can you please come here? And Dr. Chaudhary, please come and sit here.
They can sit there.
And Somshila?
He's talking.
Yeah, just come and join us. We have another 10-15 minutes for some questions. Anyone from the audience with any questions, please?
Yeah, this gentleman here. Yeah.
Can you?
Okay, Mike, please.
Yeah, okay. All the anterior chamber depths are to be measured from the endothelium to the anterior capsule, never taking into the consideration the corneal thickness. So it's an endo value, yes.
From the endothelium.
Oh, yes. If you have a myopia, sometimes you have chamber depth of 5. I wanted a lens for 5. They didn't give me a lens for 5, so I tweaked a little bit. I made it 4.5 and I got the lens. Yes. So if it's that much, that means there is an abnormality in the genesis of the eye. It could be eye with a megalocornea earlier, or a ophthalmic eye which was missed out. A megalocornea eye, which is bigger eye, can have a white to white and chamber depth which is deep. So those eyes are not meant for these refractive procedures.
Sonu, when you're ready, can you tell us?
Yeah, Sudarshan, I have a question.
I have got two questions.
Sure. Anybody?
Yeah.
The moment you're ready, tell us.
What when you have your ACD 2.78, 2.76?
Right.
What do you do at that time?
There was a study recently published, I think it's done in a Chinese group, in which they took, 42 eyes which were less than 2.75. So they had eyes till 2.55 going to 2.6768. What they found out, only, I think 10% of these patients had peripheral. On a follow-up of 2 years, they found that the peripheral little cataract formation at touch. Rest of the patients are doing well. So even off the shelf, I don't find much difference in 2.7 and 2.8. The company says 2.8, but I still go ahead and put 2.8 on my computer and I do it. And especially With the V4C coming in, I think the parameters can be changed. Now, this was
Any
with
specific investigation or any specific thing you do before when you are doing this kind of an
yeah.
ICL?
So if you think that your cornea white to white is bigger, then these are the patients in which you should measure using a UBM. I have a UBM which is 35 megahertz, so I actually can measure my sulcus to sulcus, and I corroborate same after conversion from white to white onto the sulcus to sulcus. If it's matching hand in hand, I go ahead. Second thing, I do a UBM with a 50 megahertz to see behind the iris in case my sulcus to sulcus is not fitting in well, how is the configuration behind. But that is meant for the patient in which the cornea is too big or too small, and I can't account for those. So if you have those kind of patients, in those patients, I think you've got to be very, very careful what you're doing. But I do UBM 35-50 both to see the structure behind the iris in the sulcus. Yeah.
The question is that would one consider doing a gonioscopy to see if the angles are open or not? If they are well open, you may try a sub 2.8 ACD and put it in lens. But if the gonios shows a narrower angle, you may tend to say no to the patient.
Right. So I think there was a paper by Eric Mertens, in which he says that you see the gonioscope, you see the angle. If your angle is opening wide, then these are the patients in which you can actually, manipulate a little bit here and there. On the other hand, if you have a hyperopic patient and angle is shallow, what I do in my center is I do PIs in these patients and I call them after 2 months. And to my surprise, 10% of these patients had chamber which became 2.8 after 2 months of doing PIs in hyperopic eyes. So I could manage to put a hyperopic ICL in those ones. But he's right, the angle has to be seen, and in case you think the angle is already crowding, you don't have to oversize these lenses, they can cause trouble. So in those ones, you can go for the moderate vault, according to what formula I told you.
Dr. Ernesto, Dr. Ernesto, you have any comment on that?
I have got one question.
I would like to...
A person develops cataract in a later stage of life. A person develops cataract in a later stage of life.
Oh, sorry. Swapna?
With ICL inside the eye.
Right.
How are you going to proceeding to operate, and particularly how do you calculate the power?
Yeah. Should I answer him? Okay. So when you've done a 3.2 millimeter incision surgery, your cornea has not changed. So your keratometry is going to be the same. We published some work in which we took an axial length before ICL and we followed for 4 or 5 years after, every 6 monthly. There was no change picked up in the axial length difference pre and post. Meaning that when the light goes through this thin polymer material, it does not diffract, it does not change its direction, it does not reduce its speed or velocity. So whatever axial length you're getting on the day of workup of patient with the ICL in the eye, please take that one, go in for 2.2 incision, pull this lens out, do your X-rays and do the surgery. It's the easiest surgery to perform versus the artisan lens which were available earlier, which the rigid lens was going from 5 millimeter incision and you had to enlarge the incision 5 millimeter to take the lens out. This lens actually comes out very easily from 2.2, 2.75 without any problems. So you can go ahead and you don't have to tweak your data for the IOL power calculation also, because whatever you get there is correct.
So
okay, so Sonu, are you ready?
One question, sir.
Get ready.
Yeah, there's one
So
more question.
how do we decide whether we need a high volt or a low volt, and what are the factors which we consider before that?
Can Dr.
I think
Ernesto
I just
answer
finished the
that?
talk on that.
Yeah, can you please answer on
Yeah. Well, concerning the correct anterior chamber depth that we have to have in mind when we implant an ICL, the STAR Surgical recommends 2.8, but I have my, I don't think 181 centimeters is high and 179 is a low person. I mean, it's similar. It's just a recommendation, and it's gonna depend on the correlation of the white to white compared to the sulcus to sulcus. If there is a normal correlation, you see a normal eye, I would go up down to 2.7. It's true that you have to have a limit. This is out of the record. I mean, STAR recommends 2.8, but you can go down to 2.7. I'm not saying that's the right limit. I'm saying everyone has to find their right limit. If the eye looks good, if the angle looks good, and if there is a correlation, I would go with no problem down to 2.7. But that's my limit. If it's 2.69, I wouldn't do it. Concerning the bolt, I differ a little bit from my colleague, and I rather, especially after the B4C, the BC and ICL, I prefer low volts rather than high volts. That's my personal opinion. I'm not against a high volt, but if you have to change a low volt lens, it's a lot easier than a high volt lens. You're not going to have any iris dispersion, and it's going to be a lot easier. I've had to change a very high volt, and I promise it wasn't that easy to do. It was performed, but it wasn't that easy. It's true that if you have a high volt, you can always rotate to the vertical position, and usually the volt size is going to go down. But I prefer low volts. I'm not scared of a 200 microns volt.
Can we go to the next speaker, please?
One more question.
Sonu, if you're ready, please, let's go ahead.
One more question, sir. From all the panelists.
One more question.
Yeah. One of my patients, I'm giving all the data. ACD 2.74, white to white 12.1, power minus 12.2, 12.5. Yeah. So should we go ahead or not?
Can you repeat that again for all of us?
ACD 2.74.
Yeah.
White to white 12.1 and lens power minus 12.
Okay.
So should we go ahead? All the panelists, sorry.
In my opinion, if the eye correlates and it's a normal eye, you have no problem in operating a minus 12. In that case, I would assure myself that we're talking about 274. I mean, it changes depending on the device you're using. When I have it up, I always use the OCT, the Cyrus OCT, to measure this anterior chamber depth.
Right.
But given the fact that it's 274, I wouldn't have any problem in operating that eye.
I just would like to add on that you said 2.74. The most important thing here is, apart from all the instrumentations that we use, another important thing is to examine the anatomical aspects of the anterior chamber on the slit lamp. Sometimes on an op scan, you get 2.6, but when you look at it on the slit lamp, the chamber looks pretty deep. So 2.74, along with that, if you examine the eye and if you are comfortable with the gonioscopy and everything, you can happily place a lens.
Sir, it is very difficult to decide on the slit lamp.
The endothelium.
No, gonioscopy you have to do. You should do a gonioscopy.
The endothelium is also an important aspect in this case.
Yeah,
though
endothelium is okay.
Yeah,
endothelium is okay.
Yeah, it won't be a contraindication to put in any ICL in that situation. But like Dr. Ernesto said, you will have to remain on the lower side. Error on the lower vault side rather than on the higher vault side. That is the only way you can get away with it. Because lower vaults are known not to produce cataracts, especially in the newer version of the lens.
But company people suggested me, don't go for it.
Yeah, and the traffic officers tell you not to go.
That is a grey zone. You have to decide for your own self. You have all the options before you.
I think let's listen to Dr. Sonu and then we come back to questions because we're running out of time.
Very good afternoon, ladies and gentlemen, and dignitaries on the dais. I'm sorry I'm catching late.
Dr. Khokhar, can you come up on the dais? Come on the dais.
For the questions.
Rotational stability with vision toric ICL. So we did this study to evaluate what was the rotational outcome with these toric ICLs. We went back into the literature and we had gone through these number of presentations which all gave up the single point that these toric ICLs had a wonderful post-operative stability. So this paper by Saunders, and this was the American Academy, and this was the FDA clarification for the toric implantable collamer lenses for moderate to high myopic astigmatism, where they studied that the toric ICL was stable post-operatively. Another study came up with Zone Alfonso. So, but this study had just studied 15 patients, and it had a very small figures to study. So, another study by Alonso, and this was vision toric implantable collamer lenses for correction of compound myopic astigmatism. But all these studies came out with a post-refractive outcome. So there was no gadget to find out what was the toric stability of these ICLs. So this was the first study done by Park, and this came up where they did a dilated slit lamp examination to find out the stability of the toric ICLs. The next study came up, and it was ALA who came up with the NIDAC OPD scan, where they did an OPD scan prior to implanting and post-operatively, and the outcome with this was that it was 2.8 plus minus 4 degree of rotation with the toric ICLs in the study. So these were the various studies as of now, and all these studies concluded that toric ICL is wonderfully stable, and it is usually in the range of 2.2 to maybe plus minus 4 degrees that these ICLs show their rotation. And the low rate of clinically significant axis misalignment was to the tune of 3.14%. The axis misalignment mainly occurred in the very early post-operative period. The lens position remained stable after repositioning. So if there was any case of redialing, the lenses were usually stable after repositioning. The factors which were mainly involved in slight or mild axis misalignment were basically inaccurate marking of the ocular axis prior to implantation, inaccurate intraoperative marking or alignment, minor movements of the ICL during removal of the viscoelastic, the lens adjustments to the internal dimensions, and the asymmetric lens implantations. So maybe those foot plates being poorly adjusted in the sulcus. The Vision toric ICL, so they concluded that the Vision toric ICL was effective and safe in the correction of cylinders in eyes with myopic astigmatism. So this was the conclusion from various studies, and they all showed there was only a low mean axis misalignment, which ranged from as low as 1.58 to maybe 4.03 degrees. So to extend this study, we also went back into other conditions, and this was one of the conditions which was reported by Mark 10, where the patient was subjected to abnormal gravitational force, and still under these abnormal conditions, these toric ICLs responded very well, and they were found to be stable. All these studies had certain limitations. The previous studies had used slit lamp digital cameras, the slit lamp assessment, and the OPD scans. There was no long-term data, and there was no consideration of the head tilt and cyclorotation. These all studies were more cumbersome. So we basically aimed at to have a study which gives us a less cumbersome tool, and there was no need to dilate, and the study could be done on an OPD basis. So we came out with a concept of using the ray tracing technology. So the study to evaluate the rotational stability of Vision toric ICL using the ray tracing technology. So we all know the various features of the ICL have already been discussed. I'll run through them. So the purpose was to assess the axis alignment and stability of the toric implantable Colemma lenses. And the methods, these till now we have done 65 eyes on the ray tracing with 35 patients receiving the TICL for treatment of myopic astigmatism and basically calculating out the preoperative and the postoperative axis alignment using the Zellweger caliper. So if you see here, 65 eyes, the mean age between 25 plus minus 6 and 20 males and 15 females, and the mean spherical equivalent ranged between 7.79 plus minus 3.98. The mean refractive cylinder value was between 2.46 plus minus 1.36. And in this study, just a small click. So this is a prototype picture, how it looks like the patient on the eye tracing equipment. And here we use the Zellweger caliper to find out the surprise on day 1. So this is on day 30 after a month. And so both post-operative uncorrected visual acuity and the best spectacle corrected visual acuity were significantly improved when compared with the pre-operative values. And so these are the logmar values of the uncorrected and the best corrected visual acuities. And if you see here, the mean refractive cylinder in diopters, the refraction, the cylindrical values usually remain stable, and it was just 0.32 of the axis correction as the residual cylinder astigmatism which was left as compared to the preoperative average of 1.76, and this remained stable all throughout the follow-up visits of almost a year. There were no statistically significant rotation between early follow-up, maybe 1 month and 3 months, and the final follow-up. 3 eyes exhibited ICL rotation of 5 degrees, and the remaining eyes, 96.75, had ICL rotation of less than 5 degrees. So the repositioning, as already has been discussed, is very easy. Just push in viscoelastic, go in and position the ICL into the right position. We have been using the Varion as a tool to position the ICL, and it works very well. To summarize, ICL has a good rotational stability. The minimum error of axis misalignment in our study was majority less than 5 degrees. Small degree of axis misalignment does not seem to have any impact on the visual acuity. The true axis rotation only occurred in 2 cases which required repositioning. None of the eyes required a secondary intervention after repositioning. The intraoperative alignment seems to be the most common reason of axis misalignment. So this is one very important point, that during the intraoperative positioning, you have to be very sure that the ICL sits right in the position. A limitation of the study is the axis registration method. The Visian toric ICL seems to be effective and safe for correction of cylinders in eyes with myopic astigmatism. Thank you.
Thank you. Thank you, Sonu. I would like to thank all the speakers for this wonderful session on the Star Surgicals. Thank you very much. We just have, if you can hold for a minute, we have a small lottery here. Dr. Ernesto, if you please would like to pick one. Two. One for me, one for you.
May I have some questions,
for you? So, this is the number? Yes. Whoever is holding the number 1200, 1200. If they don't come forward and pick up their present...
It's 1200.
I'll keep it. The next one, of course, is 1188. 1188. Anyone with 1188?
Please come over.
Is there? Somebody there? Yes. All right, okay. No? You two there.
Hello.
This is 1188? Yeah.
I now request Jim Francis, Vice President of Asia Pacific and North America, to honor our speakers.